communicate today. We started off with pretty much one topic, and over the last 48 hours have added two other pretty major topics. So I'm going to try my best to keep it at a half hour, but I do expect we might run over a couple of minutes, but I'll try to be most respectful of your time. So the first topic I want to cover today is our year-end data reconciliation. You should have received a copy of our press briefing that's about to go out on this, and I want to provide you a little more information and context related to that. You know, throughout the pandemic and really throughout our department's history, we have had a top priority of data accuracy. And the reason that data accuracy is so important is because we as the department provide the ultimate historical record of all of these things that we measured. So making sure it's right is of utmost importance. Sometimes that is at odds with timeliness. And I want to explain to you why COVID data reporting, the timeliness of some of those data points is a little bit different than a lot of other conditions that we talk about. And it's because COVID data is reported essentially in real time. Sometimes, just within 24 hours or so, when you're talking about cases or hospitalizations. We don't do that for any other condition. And I'm sure that you're probably sort of new to this heavy data world, just like we are on a day-to-day basis, because most of the conditions, when you think about like influenza, those are reported weekly on the cases. And for almost every condition, for the deaths are reported annually. Well, when you think about that cadence, you've got a full calendar year, and then you've got anywhere from 4, 6, sometimes up to 7 or 8 months for all of the data to come in, and then you report it once on an annual basis. That helps account for a lot of the lag that we have and lets all that get caught up before we report it. When you're reporting real-time COVID data, particularly as it relates to deaths, you all have heard me say many times, and we have experienced sort of the clearing of backlogs and what I sometimes refer to as a data dump, where we find that data has been delayed and then we add it to the system. That's what I want to talk to you today is we've been shoring up our data for 2021. The year is obviously not completely over, and it's going to take some time after the year is over for every data point to be finalized. But one in particular that has come to our attention is one pursuant to some standards that are getting ready to change in January. And it's from an agency that you probably don't hear about a lot. It's CSTE, the Council of State and Territorial Epidemiologists, which is essentially the association, if you will, of the epidemiologists. And they guide our data collection, and they work very closely with CDC to make sure we are all present, we as far as all of the states are presenting the same data points for a more apples to apples comparison. So CSTE notified us, I think sometime in mid-November, that they're going to change their reporting standards for death reporting in January. And they went on ahead and published those guidelines and asked jurisdictions or states to consider doing a look back. And as I started off this briefing, our main priority is that the data is accurate. And so we went back and we've been reviewing all of our data per the new standards, which quite frankly is not a whole lot different than our old standards, but it did require a more complete review. And we now have a new death total of 20,644. That number is accurate as of December 20th, which was Monday. So that spans the entire pandemic back to the spring of 2020. Now, what I want you to hear, if you don't hear me say anything else, these are not recent deaths. These are deaths that we have captured throughout the pandemic, although many of them, in fact, most of them, about 70%, are since August 1st. So they're essentially related to the Delta surge. I don't want people to conflate the recent spike in Omicron cases, which we're going to talk about later, with this death reporting. These are mostly older deaths that will be added to our system. Now, these will be uploaded in the week of the state week of January 4th. January 3rd is a state holiday. So on the week of January 4th, those will be uploaded then. And that is an addition of almost 2,700 to the total. So let me explain to you how these data lags and this extended time frame comes about. First and foremost, most of our providers and facilities report through a manual process as opposed to an electronic or an immediate reporting process. And there's a lot of different reasons for that. Either way is okay, but one is obviously a lot faster. So you've got one that has a turnaround time of generally 1 to 2 weeks, and then the slower method can be 6, 8, 12 weeks sometimes. And so if you think back, I know at least I have to remind myself, August 1st, or the Delta surge, was really only about 90, 100 days ago. And so we're still in that 10 to 12 week time frame. So this is not out of the ordinary. In fact, CDC recognizes that death certificate or death reporting can sometimes take 8 weeks or more, and has actually mentioned that they expect about 75% of data to be complete at the 8-week mark. So I don't want you to think we're way off base here, but the manual reporting is part of that lag. Another part of that lag, and it's something that's been a very interesting revelation to us that we're digging more into, is we have had a year-over-year increase in at-home deaths, both COVID related and non-COVID related. Well, anytime you have an at-home death, and which means not in a facility, not in a hospital, not in a nursing home, you oftentimes have an investigation into that death. Sometimes it's pretty obvious how the person passed away, but many times, particularly when you're talking about making sure whether it is or is not a COVID-related death, there is some additional investigation that takes place. So with an increase in at-home deaths, those death certificate processes take longer. And then throughout the process, whether it's upstream in the providers and at the hospitals and the facilities, the medical examiners, or downstream in our data processing, when there is a huge volume, a surge like we had in July, August, September, really the deaths peaked in mid-September. That takes everybody longer to process because just of the volume related. So let me tell you what we're doing about that. We sent out a communication to all providers on Monday. You should have a copy of that memo, strongly encouraging them to use one of the 4 methods of immediate reporting. Now, some of it won't apply. Like I told you, the at-home deaths take longer, but for those who do pass away in a facility, we have asked our providers, please use one of those 4 immediate reporting methods in order to speed up that process. I mentioned that we are looking into and exploring the reasons why at-home deaths have gone up, again, both COVID and non-COVID related, to see if there is a role, if the department can play a role in addressing that. And then the other thing that we're all trying to do is how do we incorporate this ongoing COVID work into our pre-pandemic priorities? Now, everybody is returning to trying to incorporate those things that we've always done into our normal workflow. And this is kind of a transition into the next topic, which is how do we operationalize all of our COVID work into our typical operations? I mean, it's exceedingly clear there's not going to be a date in time where this goes away or where we don't have to worry about this or work on this for quite some time in the future. I know we all hope and pray that there is, but it's not in the foreseeable future. So the impetus is on us to make sure we operationalize this, whether that's testing or vaccine, and not have a separate operation for COVID and a separate operation for typical operations. We need to normalize this into our daily routine. So in 2022, so in the new year, you will start to see us do more and more of that in our own operations here at the health department. Probably the thing that you will see most noticeably is a change in the cadence of our data reporting frequency. So I mentioned at the top of the hour that we do it daily, and there's nothing wrong with doing it that way, but that's not a sustainable way to do it in perpetuity. We're going to be transitioning into reporting data like we report other conditions. Probably the one that's most similarly situated is influenza, even though I'll tell you the differences. So we report weekly flu numbers to the CDC. We also report weekly COVID numbers to the CDC. We will be doing that in 2020 publicly. We will still report hospitalizations and deaths on a weekly basis, even though for influenza, adult influenza deaths are reported annually. So we're still going to be doing it more frequently, but you will see a more normalized cadence of our data reporting for COVID after the new year. So part of that is some differences in testing, which we'll talk about in just a minute, that I think that will make more sense to you. So just wanted to flag it for you. A couple of takeaways from that section. Additional deaths will be uploaded in the new year, first week of the new year. Those are not recent deaths; those are just through the new review process. And then, secondly, our data reporting frequency will change. Transitioning into the Omicron variant, it is here and it's here in a big way. It came very, very quickly. Just to put it in context, it took about 3 months for the Delta variant to be the predominant variant nationally. It took Omicron about 3 weeks. And so it would be completely normal for you to think, wait just a minute, you just told me last week you had 4 cases in the state, and now you're telling me it's the predominant variant. That's how fast this thing is spreading. So we have a graphic for you. Sarah, I'll ask you to pull that up. This is an estimate of the region 4. So region 4, you can essentially think of it as the South. It's the way HHS breaks down the different states. And this is, you will see a little box up there called Nowcast. That means it's a forecast. But the reason that forecasting is important here is because you've heard me say before, the sequencing, the genetic sequencing may take 2 or 3 weeks. Well, this thing is moving so quickly, we need to be able to predict it based on what we know right now and what we think it is. So if you will see the purple bars on the right side of that bar chart, that is the proportion of the Omicron variant of all cases. And you can see that in a span of 2 weeks, that it has gone from essentially none, or about 5%, to perhaps a projected 95%. So that's for the South, that's for the region 4 states. Here in Tennessee, we believe ours is around 80%, but as soon as I say that number is not going to age very well because it's moving so quickly. We don't have any reason to believe that it's not going to be at the 90 or 95% level today, tomorrow, certainly by next week. So, we've also seen a commensurate increase in our cases, not only the proportion of cases that are Omicron versus Delta, but in our case numbers generally. But I want to alert you to something that you may not be thinking about. So we have had cases in hanging out 7-day average around 1,000 or a little less than 1,000 for quite some time. And then over the last couple of weeks, our 7-day average is now around 2,200. I think yesterday we had 2,900, so I expect that average to continue going up. We think that is a significant underestimate of what the actual case burden is. And that is primarily because of the rise in at-home testing. At-home testing sometimes gets reported to us, occasionally gets reported to us, but we believe the vast majority of at-home testing is not coming across our radar. And so we don't really know what the case burden is because there is a substantial portion of at-home testing now that is unreported. That is going to continue and probably increase in the future, which is another reason that daily reporting of numbers is really not that relevant anymore. It's relevant for trends, but the actual number is not that accurate when you don't know what you don't know because people are testing at home. Likewise, that holds true for positivity rate. And so you may have seen a little change that we made in our positivity rate reporting is that right now we are only, and going forward, we are only reporting PCR positivity rate because all of the traditional PCR tests are reported to us. And so we can quote you that, and it probably mirrors that of at-home testing. But that is yet another reason that not only our data reporting frequency is going to change, but that we think this is an underestimate because of the at-home testing. Now let's talk about hospitalizations. We have seen a modest uptick over the last couple of weeks, 2 or 3 weeks. I think the last time we spoke at the beginning of the month, most of the cases were clustered in Northeast Tennessee. They're still higher than other places in the state, but their curve has attenuated somewhat in so much as they may be starting to plateau, although they are at a higher level than others. So it's more widespread across the state now. We are starting to see hospitalizations tick up, but not nearly as precipitously as we are seeing the spike in cases. Right now, we have about 1,070 hospitalizations, and we do expect that to increase, but we're not sure how much. Because this variant is moving so quickly, we're not sure yet, and because it's so new, we're not sure yet if it causes hospitalization as often. You'll sometimes hear me say that if it's as virulent or not, or if it just hasn't been enough time. You know, hospitalizations are what we call a lagging indicator, which means sometimes it'll take 1 to 2 weeks for hospitalizations to start going up after cases go up. It just hasn't been enough time yet. There is some early indication that Omicron may cause less severe disease. And so that's a hopeful sign, if indeed that holds, that we might not have as big of a hospitalization spike as we have with the previous Delta and Alpha waves. So while we're talking about what we do and don't know about Omicron, there are still a lot of unknowns. And I realize that's frustrating. It's frustrating to all of us because we want answers, but I can tell you what we do know. So we do know that the symptoms are primarily the same as Delta, although they might be a little milder. One interesting anecdote, and I'll caveat it that it is just an anecdote at this point. There are several reports that the Omicron variant does not have an effect on your taste and smell like Delta or previous variants did. I don't know if that's going to hold true as we get more data or not. The reason that that's important is that if you're thinking, oh, this is just a cold, if this were COVID, I would not be able to smell or taste. That very well may not be true with Omicron. That should not be your litmus test of whether or not you have COVID. Obviously, you need a test to tell you that or not. Another thing we know about Omicron is that unvaccinated individuals are still at the highest risk. Even if this is a milder variant, when you have a lot of unvaccinated people and a very highly transmissible variant, you're still going to have some individuals with very severe disease. There have been reports that Omicron may be 4, 5, up to 10 times more transmissible or contagious than Delta. We really don't know the real number yet, but we know it is an order of magnitude more contagious and therefore will infect many, many more people. We do know with Omicron that breakthrough cases are common. And so that's breakthrough cases is when a vaccinated individual ultimately gets infected. But we do know that vaccination, just even the primary series, does appear to protect you against those severe outcomes like hospitalization and death. Again, the longer it's been since you've had your primary series of vaccination, the less immune protection you have, which makes it really, really important to get a booster shot. And so, Sarah, I've got one other graphic that I'll ask Sarah to pull up. While she's pulling that up, booster shots are the best protection that we have. And just to orient you to this graph, the orange shaded bars, or the orange portion, are booster shots. And so you can see how the dark blue is the first dose, the green is the second dose, and the orange is the booster doses. So I'm very encouraged that over the last 6 or 8 weeks, we've had a good bit of uptake in boosters, but we've still got a lot of Tennesseans. In fact, the majority of vaccinated Tennesseans have not yet had a booster. And you've heard me say for 20 minutes now about how quickly this thing moves. It's still not too late to get a booster. We're still offering boosters even right here before the holidays. Go get yourself one. You will remember the guidance that came out several weeks ago on boosters. Mixing and matching is perfectly acceptable, or you can get the same product that you got the first time. I will remind you that vaccines.gov has a listing of all the vaccine locations with the product available. So if there is a certain product that you want, go to vaccines.gov and it will not only show you where those locations are, but which product they have. The final update I have for you is an update on therapeutics. And therapeutics is a catch-all term for medicines and IV infusions and all the different things that you can do to treat COVID once you have them. So last time we talked, I was pretty excited about the oral antiviral pills that are coming out. We still don't have them. We still don't have a time frame on those yet. We're talking to our federal partners several times a week, almost daily, and we keep being told that it's forthcoming, but I don't yet have those in the state. And so we'll let you know when those come out and where you can find those when they are distributed. Something that has been a very, very recent development is some shift in monoclonal antibody effectiveness. So monoclonal antibodies have been in relatively short supply for several months now. You will recall back in the late summer, early fall, where there was a real big run on monoclonal antibodies. Fortunately, that was about the same time that our epi curve or our case numbers started going down. So it really wasn't that big of a deal. But as cases have started to go up and the supply has remained constant, we get plus or minus 2,000 or 2,200 doses a week of monoclonal antibody and have gotten that for the last several weeks. It's been enough until just recently. And so for the last couple of weeks, we've started to hear from hospitals saying, we're running low and can we get more? And all along, we've been ordering as many have been made available to us. But over the last couple of days, we've had another pretty dramatic shift. And it's something that we're actively, even today, working with hospitals on. And that is that there's now only one monoclonal antibody product that works against Omicron. And that's the one called sotrovimab. You will hear us and you'll hear me call it Sotro for short. That is compared to a couple of others that have been mainstays of monoclonal antibody treatment, Regeneron, and a double name that we shortened to call BAM-EDI. And so BAM-EDI and Regeneron are still available, but they don't work against Omicron. Well, remember, I told you that we're estimating about 80% of our cases now are Omicron, and that number is growing. So we essentially have one monoclonal antibody that will work against Omicron. And if that weren't enough bad news, the next piece of bad news is that that supply is extraordinarily limited. We were told by the federal partners that we were to get 810 doses this week, which we did get Monday or Tuesday, and that we won't get any more until at least the week of January 3rd. It could be the week of January 10th. So essentially, we are in extremely scarce supply of monoclonal antibody. The good news, if there's any good news here in this, is we've gotten used to doing that over the last 2 years. And specifically, doctors are fairly accustomed to working with low supply products every now and then. I recall a couple of years ago, or it's probably been 5 years ago now, when some hurricanes hit the Caribbean. It's where a lot of products were coming from. We were faced with a shortage as practicing physicians of things that we've always had. And we figure it out and we figure out how to prioritize things and which patients need it the most. And so this is another time that we're going to be relying on the discretion of our providers to take this very scarce resource and apply it to those in most need. Again, working with the hospitals on that, and the federal government and HHS have not issued any guidance yet as far as stopping what we're currently doing. So we're going to continue doing what we're doing as far as with the older monoclonal antibody products until they tell us otherwise. But it wouldn't surprise me if that guidance didn't come out in the next few days. Finally, I'll end on some good news. We do have a new product in the state for a very special population. This is a product called EvuShield, EVU Shield. And this is a dual monoclonal antibody product for pre-exposure prophylaxis. That was a really big $10 phrase. Let me break it down for you. So in individuals who are severely immunocompromised, so you think of patients that are on active chemotherapy, patients that have had transplant, patients with severe immunodeficiencies. These are patients that even if they were to get a vaccine, they would not be expected to mount an immune response. So basically the vaccine wouldn't work in them. This is a particular combination monoclonal antibody product that you get before you get COVID as a pre-exposure prophylaxis, and you get it every 6 months or so in lieu of a vaccine. Again, this is a very unique and small population in our state. And so this product has arrived. It has been pushed out to select medical centers that take care of a lot of those patients. And you may have, if you have somebody in your family that falls into one of those categories, they may have already been contacted by their doctor to say, hey, we have this product, you need to come get it. If you haven't been contacted by your doctor and you fall into one of those categories, give your cancer doctor, your oncologist, your transplant doctor, any of those who are managing your immunodeficiency, give them a call and ask them about this product and where you can get it, because it offers protection where the vaccine cannot in that population. That's a lot of information, but before I open it up to questions, I want to acknowledge that you guys have been with us for another full year of getting fair and balanced information out to Tennesseans. We're very grateful for that. Tennesseans are very grateful for that. It's an extremely important role you play, and we're grateful. I hope you all have a very restful and happy holiday season. And I hope I don't have to talk to you before the new year, and so I'll wish you Happy New Year now. Sarah, happy to take questions.
Thank you very much, Dr. Piercey. We will begin our short Q&A portion. If you do have a question, please use the raise your hand feature and I'll call on you. We will start with Elizabeth Fight with the Chattanooga Times Free Press. Elizabeth, please unmute your microphone.
Hi, thanks. So my question's got a couple components, but it's all on the same topic. So what about the epi reporting for COVID deaths changed, and how much is that change contributing to this data dump? I think that'll be important to explain because I already encounter a lot of skeptics who think COVID deaths were exaggerated. So, why were these not captured before? What changed, and how are you confident that these deaths are due to COVID? And then in the reconciliation process, have y'all encountered cases of providers intentionally not reporting COVID deaths, perhaps either because the family requested it not be listed, or they maybe personally don't believe in COVID, and has that contributed any to the increase in deaths?
Yeah, those are good questions, Elizabeth. So let me address the first. I may be hearing a little bit of misunderstanding in why some of these deaths are just now being reported. There's actually two reasons, and maybe misunderstanding because I may have presented it poorly, and if so, I apologize. The primary reason that these deaths are just now catching up is the typical lag. So I went through quite a bit of detail on how 8 weeks is pretty typical, and it's not unusual at all to have 10 or 12 weeks of delay after the death before it is reported. The Delta surge was about 10 or 12 weeks ago, with the peak of deaths in the Delta surge in mid-September. So a lot of these, 70+% of these, are just the normal run out of all of that reporting that is just now getting caught up. So that's the bulk of them. The others may be more attributed to what you referenced as the new CSTE guidelines. It is quite an extensive list that can be found on the CSTE website about how to review death certificates. And so a minority of these were the old look back because of the new standards. Most of these were just the typical reporting lag, primarily because of the manual reporting that I mentioned. And that's why we encourage providers to do the electronic reporting, as well as the increase in at-home deaths. The second part of your question is, and I'll rephrase it, you can tell me if I'm missing the mark here, is about revised death certificates. Early on, we did hear of some, it wasn't many, but we did hear of reports where families did not want that listed as a cause of death on the death certificate. There have been some changes, particularly in FEMA benefits for burial expenses, that are making families a little more aware of making sure they've got the right diagnosis on the death certificate. So we do have some revision requests coming through, not many, maybe plus or minus 100, that we have had to go back and change because at the family's request, because it wasn't initially put on there, and then with further investigation it was. So it's a very minor number, but that does account for a few of them.
Thank you. The next question is to Caleb Pernay with WCYB. Caleb, please unmute your microphone.
Yeah, Dr. Piercey, I wanted to ask you with this switch to weekly reporting of COVID data, considering that the Omicron variant has a doubling time of something like 2 or 3 days, will this have us, I don't know, flying blind a little bit as Omicron hits?
So, Caleb, that's a good question, and I'm sure it's a question that a lot of people have. I would say a few things here. First of all, it shouldn't change a single thing that you do. So whether cases today are 2,200 or 2,900, it shouldn't change your day-to-day actions at all. And I don't have to go through what those actions are because everybody on this call can recite the things that I would say if I were to. The other thing is, as I mentioned it earlier, the numbers that are reported to us are becoming less and less accurate or maybe relevant, those are really not the right terms, than they have been in the past because of all the at-home testing. You heard the president's announcement yesterday. At some point in maybe late January or early February, there will be even more infusion of at-home tests. And so the tests that are reported to us are a smaller and smaller percentage of the overall, and so they're less and less accurate. So it really is irrelevant if the number today is 300 or 400 higher than yesterday or lower than yesterday. What we want to look at is trends over time. And weekly reporting allows us to do that just like we do with flu and other. And as I mentioned, we're starting to operationalize this into our typical operation. And so we're transitioning it like we do with other diseases.
The next question is for Blake Farmer with WPLN. Blake?
Um, Thank you. And on testing, can you talk to us a little bit about what role the state health department will have with any of this distribution of at-home tests, or, and this is really almost the second question, which is is there any plan to expand, sort of public testing, testing sites as we deal with Omicron?
So the short answer on states' involvement in test distribution of the at-home test is none. We have not gotten any information from the administration on that. It's my understanding just through the lay press that those will be distributed directly to people's homes after they can request them, maybe on some type of electronic portal. And so we don't have a role in that. The feds also have something called an ICAT. I believe it's ICATT. I'm not sure what that stands for, but it's a testing partnership with the large retail chains where they will be sending these low cost or in some cases no cost tests to pharmacy chains as well as FQHCs so the public can have more availability or access to that. Now, as far as our testing sites or the state's testing sites go, we still offer testing in all 95 health departments, and we will continue doing that. We have the traditional PCR test, and in most health departments, we have the at-home test where you can take it yourself at home and then mail it back in. We will continue offering that. We don't intend to stand up any additional testing sites because we already offer it in all 95 counties, and there's lots more options now. So lots of testing available. Again, as it goes further down the line, less and less of those are state run and state reported. They're more just at home tests.
And if I could follow up briefly, just on the testing I mean, obviously, I mean, even here in Nashville, they're shutting down the drive-through testing, Friday. It won't be back open till Tuesday. I imagine access could be a problem over the holidays, and it sounds like it's a pretty critical time. Is there any thought that that there should be extra access made for folks right now?
So it's a fair question, but I'll point you back to this operationalizing typical kind of testing into typical operations. I hate to tell you, Blake, this is not the last surge we're going to have, but it is a surge coming at a time that is in this transition period where at-home testing is exponentially more available than it was even 90 days ago or 120 days ago when we had the Delta surge. So I understand that weaning people off of this, you must go to the state and you must have it done here every single time. I know that's a little uncomfortable because that's what we focused on for the last 2 years, but we're starting to incorporate this in just as typical operations.
Next question is to Jonathan Matthijs with the Associated Press. Jonathan?
Hey, Dr. Piercey. My question is about the decision a couple weeks ago by the Board of Medical Examiners to take the statement off their website about the COVID misinformation policy. I know that an attorney for the health department had expressed some concerns because they took the policy off the website but didn't vote to get rid of the policy. Can you clarify what the department's understanding is of what that actually did and where things stand?
Sure, Jonathan, this answer is going to be unsatisfying to you, but the Board of Medical Examiners is an independent agency and I cannot speak for them. They are administratively attached to us, so we take care of their administrative functions, but we do not make their decisions, nor can we speak for them. It's my understanding that there is a BME meeting in early to mid-January. I don't want to quote a date because I think I'll be wrong, but I believe it's in the week of January 10th. And they intend to take this topic up then. So I could just tell you, stay tuned to that.
Okay, thank you.
Our last question is for Jackie DePiller with Fox 17. Jackie?
Hello. So as we know, majority of these new cases are people who are unvaccinated. Majority of people who are hospitalized are unvaccinated. What kind of responsibility is there on people who are using these medical resources, but they're not getting the vaccine that could prevent them from ending up in that circumstance?
So I'll clarify what you said just a little bit. I do agree that the majority of hospitalizations are in the unvaccinated. With Omicron, I can't say for sure that the majority of cases are in unvaccinated because there is a very high rate of breakthrough. But the spirit of your question is not lost, which is what responsibility do we have to these unvaccinated people? As a doctor, we have a responsibility to take care of every single patient to the fullest extent every single time. I don't think there is an adult, and maybe not too many kids in this state, that haven't heard me or others or multiple people say that vaccination is absolutely the best way to protect yourself. But you've also heard me say before that I absolutely respect and appreciate people's informed decisions. And we do that in medicine all of the time. Contrary to popular belief, sometimes patients don't follow doctors' instructions because they say, you know what, I hear what you're saying, I understand what you're saying, and I appreciate the advice, but for me, that's not the right choice. And so we're going to take care of those people just like we would take care of anybody else. But at the end of the day, vaccination is still the safest thing you can do and the best way to protect yourself, and we highly encourage it. We have to drop now. Happy holidays, guys. Happy New Year. See ya.
Thank you.